All right. Well, sorry, I've been gone for a bit. I don't remember this case because I did it for last week, and then, oh yeah, this was a acute case of a patient with a uncorrected VSD. We're seeing, I guess, a lot here given the proximity to the border. This patient has this uncorrected VSD and actually has kind of a Swiss cheese septum. There's just holes throughout the septum, which is kind of interesting. So there's multiple muscular VSDs. He has pulmonary hypertension, but what was interesting is he had hemoptysis, and he had this large, because of the pulmonary hypertension, this quite large bronchial artery aneurysm, one of the bigger ones that I've come across that was secondary to his severe pulmonary hypertension from his uncorrected VSD. So that was one case. What was this case? Oh, this was, okay, so this is a person, got the chest x-ray to download, not very clear. And you can see, what's nice here is you can see the destructive changes in the shoulders, a lot of nodules all over the place. Chest x-ray is not that clear, I don't know why. And then this patient has, let's get here, rheumatoid arthritis, and then all these nodules. And over time, they've been there for many, many years. They cavitate, they go away. So here it is older. I think that's the older one. I think this may be the new, this is the newer one. And these nodules, again, have been varying degrees of cavitation, size, coming and going. And they're presumed rheumatoid nodules. Again, they don't have any tissue off this, but has anyone seen a case of someone with rheumatoid with this many nodules? And again, they've been there for 5-6 years.
Yeah, I showed a case of not too long ago of these progressive ones, and we've seen some other ones on. They can become even confluent and get quite large in different degrees of.
Yeah, so there's.
Oh, I think
there are some.
Yeah, I think these are perfect.
Okay.
And they seem to like the peripheral lung more for whatever reason.
Yeah, and this one I kind of formed along the fissure, and for some reason it hasn't caused a pneumo. I don't know why it kind of, I guess, loculated itself. Because I've seen them cause pneumos before, but okay, I had not seen one with this many before, but again, I'm one person. Okay.
Yeah, that was going to be my question, Jeff, is that I think that they do tend to congregate along the pleura and along the fissures, at least in the few cases we've seen. I don't know if that's something that's commonly described, but doesn't that seem like that's your experience too?
That has been my experience, and the case I showed actually showed up with a pneumothorax, and it was one that they had a hard time dealing with because the lung wouldn't come back up. Caused a fistula.
Yeah. I have one that caused a pneumo, and you're right. I have to say most of the ones that I've seen, again, not one with this many, but they're usually peripherally placed or peripherally located. I don't know why that is, but that was an interesting case. What was this one? Let me see. Oh, this is just what it turned out to be. There's nothing. This is a large pericardial mass that was in this patient who presented with tamponade, and there's no parenchymal findings outside the atelectasis. And this mass was taken out, and this is more of just, it's interesting for what it turned out to be. This was taken out, and I thought it was because the history said pericardial sarcoma. I thought it would be a synovial cell sarcoma because that's, of this pericardial sarcoma is the most common, even though they're all extraordinarily rare. But this was an epithelioid hemangioendothelioma, which is a, that intermediate lesion between the hemangiomas and the angiosarcomas. Now, unfortunately, we have very early pulmonary arterial enhancement on this. This is the only pre-op study. It would have been nice if we had it because she presented with chest pain, so of course got a PE study. Would have been interesting to see how this thing enhanced over time, but this turned out to be a pericardial epithelioid hemangioendothelioma. I've never seen one anywhere, let alone in the pericardium, so I thought that was just a random case. And what is this one?
So Seth, that's it's an intermediate lesion between an hemangioma and an angiosarcoma?
Yeah, some people put it on that spectrum, and they, and they look very distinct pathologically between the two. But if you look at pathologic textbooks, because we had a case of a cardiac tumor one time that I swore was going to be an epithelioid hemangioma just based on what it looked. It wasn't as aggressive looking as an angiosarc, but it was somewhat aggressive. And anyways, it just turned out to be an angiosarc. I was trying to overthink it, but the pathologist sat down at Maryland and went over all this stuff, and I looked it up subsequently, and it's considered a somewhat of an intermediate lesion between the two. Not that it's a progressive lesion, but it's somewhere on that spectrum. It's not like you're going to get an epithelioid hemangioma to progress to an angiosarc, but it's a vascular tumor that's not as aggressive as an angiosarc, but definitely is aggressive. But that's about as much.
And
as
it can occur in multiple organs. I'm pretty sure I just saw like a restaging for a liver epithelioid hemangioma.
Yeah, no. They're usually
okay.
Yeah, they're just like angiosarcs. They can occur wherever they want, and the ones in the chest usually occur like in the heart, or but they occur anywhere. There's
Okay.
that kind of angiosarcs kind of occur anywhere. But my knowledge of these tumors is an N of 1, and reading it, I just looked about them. And this was a cool case. Just real
the most
quick.
common presentation. Yeah. The most common presentation in the chest is of lung nodular opacities, suggesting metastases that behave indolently, sometimes with lymph node enlargement. So if you see a young person, lung nodules, non-smoker, with bone lesions, think of that entity. I've never seen a pericardial one.
So what is it? How I don't know that. What is it? So what is it? It's you're saying there's multiple. They look like hemorrhagic nodules, or they just look like little nodules?
They are nodules of different sizes. Sometimes the margins are lobulated. When you first look at it, you think, oh, this should be metastatic disease. But the patient is often young, not a smoker, not particularly ill. And it's in the differential diagnosis of lung nodular lesions. And sometimes you'll see lymph node enlargement. But if you have a young person, you have a combination of lung, nodal disease, and particularly bone disease, think of that entity. Yeah.
Oh, interesting. Okay, I didn't know that at all. That's cool. Thanks. And then this is the last case, and this is just a neat case of this multiloculated cystic lesion in the anterior mediastinum. I've seen a couple of these now, and there's a differential up top when you see the multiloculated cyst, but when you get down to the inferior portion, it starts to break apart and kind of work into the surrounding. I don't know a better word. It just kind of dissolves into the surrounding tissues. It's pretty characteristic of a lymphangioma, which this was. So this was taken out and was a anterior mediastinal lymphangioma. So it's kind of multiloculated cystic lesion. Of course, there's a big differential, but I don't know if I have a coronal to show, but I find that when I see these lesions kind of look like this multiloculated cystic thing, and then portions of it just kind of work its way into the surrounding normal tissue, I find that to be at least put it on my differential, especially when some of this has a serpentine shape. So those are cases I came across since I've been here.
Wow. All right. Cool. Good stuff.
Seth, where is you? You moved. Where are you now?
Oh, me?
Yeah.
I'm at San Diego.
How's the weather?
UC San Diego. A lot nicer. That's for sure.
All right. I'll show a few since I was away for a couple of weeks, and then if there's time, I have some more. But this is a pair of cases. These were both incidental, and these are for you cardiac folks in particular. These were given to me by Chris Francois. They are some incidental findings. So the first one is a 57-year-old woman who was, I don't know the whole story, but apparently had an EKG that showed some abnormality for whatever reason. And but other than that, they ended up doing this cardiac MR to look for structural abnormality. And you'll see that there's this funny tissue flap right in here between the right atrium and ventricle. And then on the, let me show on the transaxial, so this is the axial fiestas. I think you can see some of it. We go up higher right in here. This tissue plane right here. And then this is the arterial phase of the MR. You guys can't see this, right? Probably
Right.
not.
Yeah. Yep.
There. So we can, I think you can see it in here. Let's go right atrium. Not as well in the MR, but I think you can see it on these here. So this is right here. This is a core triatriatum dexter, which is less common, which I've never seen. And same week, see another one. This is a 42-year-old woman who had some other thing, and this was incidentally detected, but you'll notice, let's see, you should see 4-chamber SSFP. There's this tissue plane here in the left atrium that you can see here. I'll show it. This is muted as well right here on the sagittal. You see this tissue plane here in the left atrium. So this is another core triatriatum. This is the more common site on the left. And she was asymptomatic as well. Must have been just minimal flow disturbance. But I hadn't seen either one of these, a case of core triatriatum in a long time. But I don't know. Have you ever, Travis and Seth, do you ever come across these incidentally on your cardiac?
On the left, yes. And on the right, I've never seen one, but it's just random. An old fellow of mine just sent me one like 4 or 5 days ago, and I've never seen one. But the left, we do see these incidental ones.
Okay.
Yeah, I've never seen one on the right either. We had a recent one just on a cancer restaging a few days ago on the left, but usually if they're small, not restrictive, it's not that big a deal.
Yeah, so they're not going to do anything about either of these. Okay, and this is a case I mentioned to a couple of you guys earlier this week. This is a 3-year-old who was involved in a sort of medium energy trauma and was doing fine. This is his abdominal, so they only did an abdominal CT on him, and he had some bumped troponins, and so they did do an echo and saw some wall motion abnormalities in the inferior left ventricle. So in retrospect, looking at his abdominal CT, you'll see there's an area of decreased perfusion or attenuation involving the sort of distal LV towards the apex and inferior wall. So they were worried about maybe a coronary injury. I don't know if he had quite enough mechanism for that, but given the troponin and abnormal echo, they decided ended up doing a CT angio. This was done without sedation, but cardiac gating. And you can see the coronaries themselves looked fine. I threw in the whole sequence, but there was no concern about the coronaries. But you do see this decreased perfusion, and I'll show some reformats that I think look better on these short axis reformats. And you'll see that there is some sort of thinning here of the left ventricle near the base of the heart. And so the question was this something that was old or congenital? Or is this just a small myocardial contusion or localized ischemic injury? And after talking to some of you guys seem to think this was probably more related to the trauma, given the history, the bump troponin, the imaging findings. And they're managing it just with some aspirin, and they're going to do a follow-up. I think they're going to try to do a cardiac MR as a follow-up and or an echo in the future, just to make sure.
What's interesting is when I was initially looking at it, I didn't really appreciate the pericardial effusion. I think that also
good
something that's a little more in the acute. That's a pretty good size effusion.
Yeah, and it really wasn't.
I don't understand. I mean, what he was in a golf cart, and was it because
apparently he crawled into the golf cart and it was left unturned on, so he sat on the pedal or something and it drove off. Who knows? I didn't dig into the story too much. I didn't think it was that relevant.
As
so I know it's just like you need just a major force to do that. It's just
it looks like he aspirated too when he grabbed. But they didn't see his chest at that time. But the thought was his coronaries are okay, and this may be direct myocardial injury.
There was no root fracture, was there, Jeff, overlying that? Or sternal fracture?
Not that we could see. But you know how kids' bones are. They're so plastic. But there could be I didn't even see a cartilaginous injury. It looked pretty good. I think the kid was doing pretty well too. I mean, I think they were getting ready to discharge him. So
probably had a bruise on his chest.
Yeah, I suspect he. That's the one thing we're not privy to.
Yeah, Jeff, I showed this to Art as well, and he had suggested the idea of an MR and was wondering if this was just stunned myocardium.
Yeah.
I don't know. I mean, it depends on how severe the trauma was, but you can get acquired VSDs from trauma. Usually you get more mitral valve papillary muscle rupture and injury like I showed a few weeks ago, but it's an interesting case.
Yeah, it is. If I get any follow-up on it, I'll see what, I'm sure they're going to bring them back and re-image them, probably with echo would be my guess. And then just real quickly, this is just a nice classic case for the trainees out there. This is a 3-year-old. You can see has all these collaterals here and this nice juxtaductal coarctation. Here's the 3D. You can see the coarctation. But as my first question was, well, what's the aortic valve look like? And you can see, I think right here, really nice example of a bicuspid valve. And then just really, he's got pretty sizable collaterals. You can see all these, especially above the, below the coarc, these intercostals and sort of coming to the mediastinum, but just a nice classic coarctation. I didn't find any other matching anomalies to go with this one. All right, I'll let someone else go, and if there's time, I got a few more. If not, I'll save them for next time. All righty, who would like to go next?
I could show a couple.
All right.
So let's see. Can people see a röntgenogram here?
We do.
Okay, so this fellow came through for a B reading earlier this week, and I was struck by the ancient aortic valve replacement that he has. This is I think this is maybe a Bjork-Shiley valve. So it's a ball valve in a cage. You guys might not have seen these things, but this was what they did back in the 60s and 70s. And the other striking thing about this man here is that he's got all of this cartilaginous calcification of his trachea and proximal bronchi. So he's got a nice calcium bronchogram for us here. And usually you see this in women, not older women, but not in men so much. But in this guy, it's probably related to his aortic valve surgery in that he was on warfarin for forever. So he's been on warfarin for decades, and warfarin or Coumadin can lead somehow, some mysteriously, to calcification of the tracheal cartilages. So that, I think, is the explanation in this guy. I checked his dose of Coumadin. He's on 5 milligrams, alternating with 7.5 milligrams every day. So calcification of tracheal and bronchial cartilages related to Coumadin. So people talk about this mechanism that there's some protein that's being blocked that's related to vitamin K that has to do with restraining calcification in cartilage. Somehow that protein is blocked, and therefore people precipitate calcium in cartilage. It sounds like hand waving to me. So do you guys have a better explanation, a mechanism?
I've never found a good mechanism, David.
Yeah.
Hey, quick question. Isn't that a Starr-Edwards valve? I thought the Bjork-Shileys were the one with the tilting discs where the discs...
You're absolutely right. Yes, this is, you're right. This is even older. This is a Starr-Edwards. Yeah.
I've seen a few of these still coming through.
They last.
Yeah. Although I bet they're really... And I've seen one with the metal ball. That looks like a lucite ball, maybe.
Yeah, it's
I
plastic.
have a good one with the metal ball on a gated CT. You can see the thing flapping around. It's pretty cool.
So on the lateral view, it looks like it's during systole because the ball's suspended at the top of the cage.
Oh yeah, look at that.
Right, and these things make a lot of noise. These things make a ticking noise too. So you can detect these in the room with the patient.
You know, I recently heard a story about a professional poker player that ended up having a prosthetic aortic valve, and it ruined his poker playing career because his heart rate would go up.
Right.
And then everybody could hear it going up at the table.
Yeah.
Where did you hear that?
I can't remember.
Sounds like aortic valve folklore to me.
So here's another case of, this is one or two cases I want to show of GPA here. This fellow had this antecedent extensive rib trauma, but he did have these patches here. He had shortness of breath. He had a lot of arthralgias, and he has CT. He has a variety of imaging showing a variety of findings related to his GPA. So some of his CT scans show patchy consolidation here that might be some nodular things with some surrounding hemorrhage. There were other instances where he had profound hemorrhage, as in this case here, a lot of hemorrhage that settled down to the bases on both sides. And this CT scan shows a more discrete scattered lesions like this. So this man has GPA and all of these findings here. And let me show you a different case. Let me see, first of all, if I have the, one of these guys has this, okay. So this is a, this guy has extensive necrotic skin lesions here from GPA. So you can see these lesions here of toes and fingers, pretty dramatic here, and that's really why I wanted to show this particular case. So this guy's presentation was with this severe peripheral vasculitis, and let me see what his, yeah, this is the same guy with the CT that I just showed you. So a variety of nondescript lung lesions here, but very striking skin lesions in this guy from GPA. And the other one I wanted to show is this other case of GPA. This turned out to be the same case I just showed you. I'm sorry, guys, to get this wrong here. Okay, so here's our first GPA case, the guy with the skin lesions, and these are his more characteristic lung lesions of GPA. So I'm sorry, I got these run together. So these discrete lesions here were his GPA. Here's his rib trauma and everything like that. The other guy had the scattered lesions and eventually ended up with chronic renal failure, chronic liver failure, and this huge heart here, pulmonary hypertension and so forth. And this was the last radiograph he had before he died. So a variety of lung lesions, including hemorrhage, patchy consolidation. His biopsy showed organizing pneumonia, which is one of the patterns you can see in GPA for the lung lesions. And he ended up dying of a lot of arthralgias, a lot of arthropathy, renal failure, and liver failure.
David, did any of them have airway involvement?
No, I checked for that, and the airways were clean in all the CT images that I had. Okay.
All right. GPA Rama. That's interesting because, you know, it's a pretty rare disease. I mean, I forget the incidence, but it's pretty low.
Thank goodness.
And the other thing I remember is it almost exclusively occurs in Caucasians. It's very unusual to see it in other ethnic groups. It's one of the HLA types that's, I forget, it was D something that I think goes along with it. All right, Travis or Howard?
I've got a few.
Okay.
Yeah, I can share some afterwards too.
We've still got half hour, so I think everybody will be able to go, and then we may have a few extras.
You see my screen?
Uh-huh.
Yeah.
Okay. This is a quick one, but like one of the ones Jeff showed, just more basic. It's early in the academic year. And you'll notice this lady is prone, and it's because she has a surprisingly symptomatic mass posterior to her scapula on the left side, well, deep to her scapula, and I guess extending posteriorly. And this is the first one of these I've seen where the patient was clearly symptomatic from this. Apparently she's had a mass for several years, but it's over the last 2 years that it's become painful when she sits in a high-backed chair or when she sleeps or tries to sleep on her back. So the location, this look with the kind of fat interspersed with soft tissue is a great look for an elastofibroma dorsi. They did an MR, which I don't know if it was really necessary or not. And you can just see it kind of has that same look with some fat interdigitating throughout it. I don't know if there's much else to show other than that. But they did go and take this out, and this was path proven as an elastofibroma dorsi. So they had done an outside hospital, an ultrasound guided biopsy a while ago, which also didn't really help that much. But just typical location, a little bit larger than usual. And you can see here that she had been symptomatic for the past 2 years, which I thought was kind of interesting, because usually those patients, they just discover them incidentally.
It's a little bit more posterior than I have seen before, but otherwise it looks the same.
Yeah, it's still here. It's still deep, and I think it's just more that it's
Positional.
kind of extending out posterior. Yeah, because maybe it has nowhere else to go just because of the size of it. And you wonder if she's got a small one on the other side developing too, since they're frequently bilateral. But yeah, good look in that location.
Yes.
All right, that was a quick one. Let's get into some more interesting ones here. This is one that I showed the non-con CT a few months ago, and this is, oh, that's not, what happened here? Here, this one. And I showed this as a consult because we didn't have the answer at the time, but I do have an answer now. And this is a lady who's 25 and she's had surgery in the past. She had a coarct that was repaired, as well as a PDA that was ligated when she was a kid. But she was from the Middle East and just came here for lung transplant referral. And this was a non-contrast study because she couldn't get contrast at the time. And I thought this was one of the more interesting non-contrast CTs I'd ever seen, because her lungs both show completely different, opposite patterns of each other. If you look on the left, she clearly has what looks like pulmonary arterial hypertension. She has massively enlarged pulmonary arteries, all the way to the segmental and subsegmental relative to their corresponding bronchi. She has some of the central lobular nodules that we typically see with pulmonary arterial hypertension, the little plexiform arterial lesions. And then if you look on the right side, it's a completely opposite picture. She has a lot of septal thickening, and and this is diffuse throughout that lung. She's got a lot of just cuffing of the bronchi on that side as well. She has these weird little calcifications along the bronchovascular bundles as well. And so when I saw this in consultation, I looked on the right side and I was worried that there was no pulmonary vein because I couldn't see any on that side. You can clearly see the left side one. So I was wondering if this was, for whatever reason, a unilateral veno-occlusive process, as well as the pulmonary arterial hypertension on the other side. And so forever she refused to get contrast, and I don't know, she ended up back in the ICU, coming back and forth, and ended up on ECMO. And they did this as part of her heart and lung transplant evaluation. And you'll see, first of all, looking at her heart, like Seth's case, she still had this huge VSD that had never been corrected, which explains why she had the pulmonary arterial hypertension, at least on the left. But if you look on her right, sure enough, she has, for whatever reason, no pulmonary venous drainage back into her left atrium. And nobody knows why this occurred unilaterally. But unfortunately, she ended up passing away a month or so ago. But it was just really interesting because the imaging explains the physiology, but we still don't really have an explanation for why it occurred like this. And you can see now she's on ECMO and just has developed that kind of ECMO lung with diffuse ground glass opacities everywhere. And so we were wondering, even if some of this calcification was just lymphatic congestion along the bronchovascular bundles. I don't know, we're just speculating, but just a really odd case.
Travis, what about like a fibrosing highlitis from either old histo or TB, and that would explain some calcification and the sort of that soft tissue in there and the lack of a
yeah, it would. The one thing I forgot to mention is notice that her right pulmonary artery is really small, just diffusely small relative to the left too, which makes me wonder how long this has actually been there. Because certainly, yeah, that's a good thought for a unilateral, obstructive process of the pulmonary veins. But
and pulmonary artery being narrowed. So I think the pulmonary artery is being pinched rather than, this or even sarcoid. Remember, there were some cases of sarcoid that we've discussed with sort of a fibrosing mediastinitis pattern that includes pulmonary veins. There's a lot of tissue in the mediastinum there too. I wonder if that's some lymphadenopathy. It's quite a bit.
Yeah, I don't know.
What is that enhancing? Is that all lymph nodes, that conglomerate stuff?
I don't know. On the non-con, I was chalking it up to.
I thought it was going to be like edematous stuff from lymphatic,
Yeah.
poor lymphatic drainage, but it looks.
Yeah, I don't know. It's really
Travis,
bizarre.
anything in the spleen? Any calcification in liver or spleen?
Some extreme zoom right there. Let's see. No.
Big.
And she's from the Middle East. I don't even know what the.
Oh, I bet it's maybe old TV.
Yeah,
Yeah, I mean, I guess that's a reasonable thought. But yeah, whatever it is, it's a really interesting physiology. And so she had, of course, was going to have to be listed for both heart and lung transplant given this, and given her uncorrected ventricular septal defect. So I don't know why she ended up with a PDA closure, a coarct repair, but not a VSD repair. And nobody could ever get her old hospital records to try and figure it out.
no apical lung calcifications to go with TB.
No, but I think it's just, yeah, because on this one, we were just going to chalk this up to weird lymphatic tissue or collaterals in the mediastinum. But you're right, it is pretty vascular.
And it's.
But I thought, yeah,
I think
I just thought it was a good example of showing, you know, whenever you see unilateral septal thickening, always think about pulmonary venous obstruction
right
as a cause. But so, David, you were going to say something else.
No, no, I'm with you.
Yeah, so we won't know, but it's a good case of physiology. All right, let me show this one. Let's see. I'll give you a second to look at the radiograph. This was one, it was kind of cool just because the location of the abnormality is classic in some texts, but one that seems pretty uncommon, and then the look is a little weird too. This is a 31-year-old man with HIV, well controlled, came in with upper respiratory symptoms, had this radiograph, and they discovered this right paratracheal abnormality. You can see there's some mass effect on the trachea. Certainly is pretty big, doesn't look like it would be any sort of vascular thing. He has a left arch, so you don't expect this to be a double aortic arch. The lateral's not all too helpful in this case, not a great lateral view. And then he underwent CT, and you see that it's this vertically oriented, multi-lobulated thing that has areas of soft tissue, or mostly fluid, a little bit of intermediate attenuation, and some rim calcification of parts of it. It also has a nice little separate superior aortic recess. So right paratracheal region, sometimes we see nerve sheath tumors in here that can have complex looks. But this was thought to be most likely a bronchogenic cyst, given the location and this kind of weird look. I don't know. I was thinking more towards the nerve sheath tumor myself.
I was thinking.
My colleague who read this thought this was going to be a bronchogenic cyst. They did an MR, and you can see it's intermediate to high on T1, probably some proteinaceous material, and then on the T2, you'll see that it's given the field heterogeneity, that it is high attenuation and fluid attenuation. And there wasn't a lot of enhancement, or really any, maybe a little in the wall, but they did take this out, and this turned out to be a bronchogenic cyst. So I thought that was kind of a cute one because it's a little bit unusual since it's more complicated than we usually see.
You wonder if it hemorrhaged at some point, explaining the high attenuation of the calcium.
Yeah.
Or previous infection or something. I don't think I've seen one calcify. I've seen.
Yeah, and the reason that it's and that would explain kind of why it's multi-loculated like this too. I mean, it's a weird look.
I'm surprised you were picking it up de novo at the age of 31 with HIV. You probably had chest X-rays before. Maybe people didn't see it or tumble to it.
That's a good point. You're probably right. Unless it enlarged, like Jeff said, from hemorrhage or something, but he wasn't symptomatic from that.
On that frontal projection of the chest, it's a nice example of the cervicothoracic sign from the Felsen days.
Mm-hmm.
So you can see that the interface with the lung, as you get to the thoracic inlet and just above, fades out.
Yeah, right in here.
Where that interface sharp is no longer sharp.
Mm-hmm.
And that's a nice cervicothoracic sign. So you know it's not posterior in the hemithorax or paraspinal, and you know it's not anterior, even without seeing the tracheal displacement. It's a so-called cervicothoracic sign. A nice example of that one. Nice example of it.
Yeah. All right, I'll stop there. I've got plenty more, but I'll let Howard show some, and then we can just go around.
Sounds like a plan. All right, Howard.
Okay, this one I will show you a couple of images before giving you the history, because in this patient, the clinical context is really important. So this patient came in quite symptomatic, and you can see why. He's got a lot of consolidation in his lungs. I think this was to the emergency room. So this is what the frontal and lateral projection looked like. Let me take that away. But basically bilateral lung consolidation and quite extensive. So I will leave that up and I'll put alongside the CT from the same day. I'll just do this. So we see the extent of the opacities in the lung, mostly in the apical lungs, upper lobes. Interesting how it really spares the periphery of the lung, which is really interesting. And I'm going to show you a follow-up before I give you more information. So the follow-up I'll put over here on this side. So the follow-up is that period of time, just about a month. So to go back, this is what it looked like in July, and this is what it looks like now. So you can see the process is, or has evolved to one in which there are smaller but more attenuating opacities, but also with some architectural distortion of parenchyma around the opacities, but otherwise they correspond precisely with what we see before. So the history is really important here. Let me bring up the information here. This is a case of radiation pneumonitis from yttrium-90 treatment. So he has a hepatocellular carcinoma. They're known to be associated with shunting between the hepatic arteries that supply the tumor and pulmonary veins, such that some of the material that you inject via the catheter can go to the lungs. Here you can see pre-procedure, they evaluate the extent of shunt to the lungs, and that was calculated at 14%. So here is an article that talks about this thing. So this is radiation pneumonitis. And typically when you get a shunt fraction more than 10% or so, you begin to worry a bit. I think if the calculated shunt fraction is greater than 20%, then they don't do the procedure. So here are some images from the shunt calculation, and you can see that there is some activity within the lungs and forward. So once one had all that information, the findings are pretty typical of radiation to the lungs with some scarring happening. This is the first one that I've seen. Have you guys ever seen that before in real life, or
Never.
a real case of that?
No.
Pretty dramatic, isn't it?
I thought it was going to be pneumocystis. It sure looks like pneumocystis to me. I think he's told his pneumocystis. I'm going to go with pneumocystis regardless of which
I was
one.
going to say drug-induced organizing pneumonia.
Oh yeah. But what's interesting, it's so upper zone predominant, and if it was if you would figure if this was embolization, it would be more lower lobe.
Huh.
Yeah.
That's one of the oldest images of organizing pneumonia I've seen.
On the initial study, was it more? On the initial study, was it more upper or lower lobe predominant?
The initial exam, it was pretty much where you see it was definitely upper lobe here.
Because I was thinking it was more of like a permeability edema type of look. I thought maybe you were going to say that he was a cocaine user or something.
Yeah, no, it looks like cracked lung. It does. It looks like cracked lung, inhalational injury, whatever. You know, that's cool.
So I guess the question is, is it the radiation from the yttrium, or is it something else in the substrate that they inject that causes a chemical pneumonitis?
I think it's thought to be radiation from the atrium. You know, a certain number of those spheres go up there and impact in the capillaries.
Huh.
Here is a picture, obviously, from the one they had in this particular article that they show of this, and it sort of spares the periphery like that. It just seems to fit very nicely with what has been described. I've not seen one before.
Wow.
And
you know, in people who are lying on their back, ICU patients, you'll often see edema drift to the apex. And so I think that our notions of edema being basal predominant are based on people who are sitting or standing, not people who are lying in bed for long periods of time. So this procedure,
that's a very good point.
In bed, I'll bet you this is where his blood flow went.
Yeah, but you're right, because he was lying flat when they injected the spheres, so
yeah,
he's not going to have that gravity-independent change as much. Maybe that explains.
Well, and the comment about organizing.
And they say it does occur.
I was going to say, I mean, even with some of the stereotactic radiotherapy, the early injuries, we see what looks like little patches of organizing pneumonia as well. I think that may be a response to the radiation.
Yeah,
it's a response to whatever injury it is. The question is,
exactly,
what's the injury?
I think it's a direct induction from the radiation, but that would be my guess.
Mm-hmm.
I mean, that would have to.
But I agree. Yeah, I mean, you know, it's all just organizing pneumonia. I mean, with any of this stuff, it's fascinating. It's a beautiful pattern.
Yeah, it's really cool because I mean, it seems like there'd have to be a lot of radiation delivered to the lung. Because Jeff, usually when you see lung-induced radiation pneumonitis, then it's, you know, a high dose delivered to areas of the lung.
Right.
But
no, you know, like in the old days or with some of the mediastinal radiation, you see those nice sharp margins and the injury field. But with these, you know, the stereotactic stuff, you see sometimes early on sort of peripheral areas of consolidation or ground glass that, you know, and then on the next one it coalesces down and looks more like, you know, the second time point where you get volume loss and distortion where the treatment was concentrated. Well, it's really cool.
Yeah.
Howard, that's a neat case. I was not aware of this.
Yeah, it fits in terms of timing too. I think it's described as patients becoming symptomatic a month or more after the performance of the procedure, which was kind of the case here too.
oh, so it was
about
more than
2
a month
months.
after? Yeah, I guess that makes more sense for radiation than just a drug-induced pneumonitis.
Yeah, this is September 4, and the procedure itself was on May 15, I think it was. So he was symptomatic at that point in time. Procedure was in May 5.
So the CT was from when? The CT was from August then, or
September
July.
4, the first, excuse me, July 4, excuse me. Independence Day, yep. Looking like that.
Very, very good case.
That's cool.
Cool.
I'll show one more from, this is courtesy of a colleague in London, Mary Roddy. She saw this case and remembered that we have shown in the past a number of cases of meandering pulmonary veins as an incidental finding. So I'll show you this one. This person does have a lesion here, which they think is going to turn out to be a cancer, but the incidental finding of the pulmonary veins. So as I scroll through, you'll see veins going in every which direction, even anteriorly, but they become larger here, and you can see them going down here. It's bilateral. In the lower lung zones, you can see the veins meandering around. All of them are traced to the left ventricle, to the left atrium, so there's no connection to the right side. I looked for abnormalities of lobation, but I didn't see any. I thought there might be fissure down here, but I'm not sure about that. Here are a couple of VR images showing you some of the meandering pulmonary veins, but all going basically back to left atrium. So just another example, incidental finding, anomalous, or rather meandering pulmonary veins, but all connecting to the right place ultimately. Oh, here's the coronal MIP that I made that shows them quite nicely, so you can see them there.
That's cool.
Weird.
Yeah, yeah. All right, Jeff. Sorry,
So,
go ahead.
And Howard, the tracheal branching was okay. I mean, the bronchi were well behaved. They weren't weird.
Yeah, I looked for abnormalities of lobation of some kind or another, but they all seem to be in the right place. Upper lobe coming up there, lingular, superior segment, right middle lobe, lower lobes.
Got it.
No, certainly no major lobation abnormality that I can see. I was wondering when I got way down here whether there was, and I can't remember where I saw it, whether there was an accessory fissure down here, but I can't even remember what I was looking at.
Okay.
Let me see. Okay, I'll keep my others for another time.
Okay.
Actually, can I show one real fast?
Yeah. Go ahead, please.
Won't take long. Okay, so this one is a radiograph which is subtly abnormal, so I'm really going to go by that because to actually see the airway abnormality that I'll show you next is really hard. So that doesn't look bad at all. And then this is a CTPA, and if you were reading a CTPA and said no PE, but then saw this, so look at the extent of airway abnormality. So proximal generations of bronchi have thickened walls, but there is a substantial amount of intraluminal material within those proximal segmental bronchi as well. And you can see a lot in the right middle lobe, and you can see a lot in the lower lobes. So substantial amount of airway abnormality, but not so much bronchiola. In fact, I don't see bronchiola, it's all the larger airways. So there is a history here, but they did some additional testing. And as you can see from what I'm showing you here, based on this panel right here and some of the history, they've concluded this patient has ABPA. So she's got a very high IgE level. She's got antibodies IgE to Aspergillus fumigatus, as you can see there. She does have a history of inflammatory bowel disease. Interesting that she has reported that she's received steroids before, which presumably cleared it up immediately, she said. So at least based on this and the history, they're going to treat her again with both steroids, but also antifungals, having made a diagnosis of ABPA. And certainly the imaging findings, I think, are quite consistent with that.
I'd say the imaging finding looks more like ulcerative colitis from the
same thing. It's so uniform, and maybe she has both. Because
well, I guess you're showing mucus impaction there and the bronchiectasis in the middle lobe. So I guess maybe she has both because that central airway thickening with the profound thickening of the posterior membrane, that looks like some of the inflammatory bowel disease associated.
And her trachea does not look quite known.
Bronchitis you see with EC.
That posterior wall
is all the way up there too.
Wow.
And you don't usually get that with ABPA.
No, you don't.
Yeah. So you think the tracheal wall is substantially thickened, certainly like here, for example?
Yeah.
Well, even up higher, you're showing.
That's just not. That's fascinating. That could be both.
No, granulomatous tracheobronchitis and maybe ABPA as well, because there's a lot of stuff in the lumen, right? In the lumens, yeah.
Wow.
Yeah, why not? Why not both? Because she's got chronic.
Or the granulomatous tracheobronchitis predisposed her to colonization with Aspergillus. That's really interesting.
2 years of age, and apparently psoriasis. So, yeah, I guess you can have both. That is interesting, isn't it?
It is, yeah.
Oh, all right.
You guys know, both. Do you get sinusitis with the inflammatory bowel disease associated airways as well?
I don't know.
I don't know.
Not something that typically I associate with severe and surgery. So I'm not sure about that.
And they checked they checked her for granulomatosis with polyangiitis, given the sinus disease and that airway thickening?
They have.
Yeah, if they've looked at her echoes. I'm assuming they have. That's a really interesting case.
Yeah.
But she has ABPA, right? Because the definition is, does she have eosinophilia? I mean, because it's history of asthma, it's elevated IgE, it's positive skin test, and it's peripheral eosinophilia. Those are the only, that makes the diagnosis. So definitely has ABPA. I mean,
but it's probably, as we're saying, it's probably aspergillus on top of some other airways.
Yeah. No, I agree. It's a fascinating case.
Yeah.
I don't know about the eosinophilia. I'd have to check about that.
Do you usually see sinusitis with ABPA too? I think so, but I'm not sure.
I don't know.
You don't have to. Howard, these are great cases.
No,
Yeah,
I didn't.
Like Seth pointed out, the trachea up high even is way too thick, both posteriorly and
Howard,
anteriorly.
I'm telling you, when you send that, I'm going to use it for my ARP tracheal lecture and bronchial lecture. That's an amazing case.
Yeah. Up there. I think I went by that.
With credit, of course. But that's awesome.
I think we might, if this person were older, you might think of amyloidosis too as a cause of this.
You know what? I was thinking right when you showed the bronchi, I was saying this is going to be a case of amyloid. That was my first thought.
Right.
Yeah.
That was exactly my first thought.
Finding to go along with it is the mosaic attenuation. You got some beautiful air trapping in the lingula and the lower to go along with the large airway disease. That's a beautiful.
Nice.
Yeah, because you wonder if she really has a diagnosis of asthma. And I'm not saying that she doesn't, but with that degree of tracheal and bronchial wall thickening, you know, it could all be due to her underlying inflammatory bowel disease.
And then just has bad luck to have these other findings too, huh?
Well, I mean, I think she's susceptible to colonization with aspergillus, so I think that's just the icing on the cake.
That's really neat.
I'll check for more lab eosinophilia and I'll let you know.
All right, Seth.
All right, take care, guys.
It's about time, so thanks. And Travis and I will be away next week, so it'll be up to you guys if you have enough attendance to have it or not, okay?
Alrighty, thank you.
Thanks, bye.
Bye.
Thanks.